everyone, I'm Jackie. I'm the CEO of Tuberous Sclerosis Australia, for those who don't know me. Really pleased tonight to invite along and welcome Dr. Fiona McKenzie, who's a clinical geneticist with Genetic Health in WA. And as I'm pretty sure you'll all know because you've signed up for this evening, Fiona's going to talk to us about genetic testing and TSC. We are recording this session so that we can put it up on the website afterwards and play back. And the intention tonight is to let Fiona run through her presentation and tell us a lot about genetic testing and when and whys and some of the sort of facts and figures, and then obviously open it up for any questions that you may have. So without any further ado, I'm going to hand over to Dr. Fiona McKenzie, and thank you for coming on this evening.
Hello, everyone. Can you hear me? Yep. Okay, good. Thanks very much to Jackie and everyone for inviting me to talk to you this evening. As Jackie said, I'm going to be talking about genetic testing in tuberous sclerosis. So hopefully that will help answer any questions that you might have, or, and provide a little bit more information about what we do and what that might mean. Can you see my screen at this point or not? Can you see me or can you see my presentation?
You can see the screen.
Excellent, right, okay, because I can see sort of me in one corner and I can see the screen obviously here, so, all right. So I'm basically going to, if I can get it moving. Why is it not moving? Ah, there we go. Okay, I thought I would start by making you suck eggs in some respects, because you probably know this already, but just a brief description of what tuberous sclerosis is and what causes it, and then we can sort of move on to being a bit more specific about the genetics. So as you all probably know, this is a genetic condition. It's inherited in an autosomal dominant way, meaning that you only need a variant in one of the two copies of the relevant gene in order to have the features of TSC. And it can affect multiple systems in the body, and that can include the brain and the kidneys, the skin, the heart, and potentially the lungs as well. There are two genes that are known to cause TSC, the TSC1 gene, which is located on chromosome 9q34, and the TSC2 gene on chromosome 16p13. And they respectively code for two different proteins called hamartin and tuberin that regulate mTORC1, which stands for mechanistic target of rapamycin complex 1 pathway, which is a pretty critical regulator of cell growth and proliferation and autophagy. So in other words, these proteins are important for regulation of multiple functions within the body. And this occurs in about 1 in 6,000 to 1 in 13,000 live births. So that varies a little bit from place to place, country to country, but that's roughly the figures. The most common presenting features are epilepsy, with 80% of individuals having an onset of seizures under 2 years of age. And the most common types of seizures, particularly early on, are epileptic spasms and focal seizures. Focal meaning that they're coming from one specific location in the brain rather than being more generalised. But you can get a whole variety of other seizure types as well. The risk for seizures is correlated with the number of tubers in the brain. And tubers are basically changes in the brain that are basically growths that are caused by either the TSC1 or TSC2 genes not working properly. And the more that you've got, the more likely you are to develop epilepsy or have more difficult to control epilepsy, and potentially has an impact on neurodevelopmental function as well. The seizures in TSC can be very challenging to manage, so they're not always responsive to just one medication and sometimes require multiple medications. And I'm sure that some of you may well have had experience with that. The other more common presenting feature, so probably the second most common, is cardiac rhabdomyomas, which again are benign muscle tumours that are often detected antenatally in the ventricles of the heart. And probably if you see that on an antenatal ultrasound, about 80% of the time that's representative of a baby having tuberous sclerosis. But in a small percentage, that may not be the case. The third most common presenting feature are the skin changes that you see in TSC, and I'll show a few pictures and talk a little bit more about those, but they're often age dependent. So in other words, you may not see those changes or all of those changes at a really early age. And then sometimes this can be diagnosed when, something is detected in the kidney. So someone might have a routine ultrasound or an ultrasound of the kidneys investigating a urinary tract infection or something else, and they find some of the typical features of TSC, which might lead to that diagnosis. The other way it can be diagnosed is if some other member of the family is diagnosed, and that leads to either genetic testing in a family or seeing other family members and looking to see if they've got any clinical features. Okay, so how is TSC diagnosed? Well, you don't need genetic testing to diagnose TSC, generally speaking. So basically, there are a number of clinical diagnostic features, and if you've got enough of those features, that's enough to make the diagnosis. And this is just a table from a publication talking about the diagnostic criteria for tuberous sclerosis complex. And as you'll see from the table, there are a number of major criteria, which I guess have a higher weighting in terms of their importance for diagnosis, and a number of minor criteria. And you can establish the diagnosis of TSC if there are two major or one major and two minor criteria. And then possible TSC is when you have one major or more than or two or more minor criteria. You can also establish the diagnosis if you've got a variant within one of the two TSC-related genes. That's another way of making the diagnosis. These criteria were updated in 2021, and so they're the most recent criteria. I'm not going to go into detail with those. And this is just gives you an indication. Again, this is from another medical journal that is talking about TSC, and it's quite a nice little table giving you an indication of when some of the features might occur in a person's life. So as you can see, the rhabdomyomas in the heart, the tubers and the subependymal nodules that you can see in the brain on a scan are often things that may occur prenatally or early into neonatal life. Seizures will often develop very early. SIGA, which is the sort of giant astrocytoma, which is a benign tumour, but it can cause issues. Usually you'll see from around the first couple of years and presenting, continuing to potentially occur up into adolescence and adult life. And then this is the skin changes. So the hypomelanotic macules, and you can see on this picture at the top here, this is more obvious because this person has a darker coloured skin, but they're really light coloured nodules, and they've also been given the name ash leaf macules just because they look a bit like an ash leaf. So they're often present from quite early on. But you won't see the shagreen patches, which looks a little bit like a sort of a plaque on the skin, often in the lower back region, and the periungual fibromas, which again you can see there on the toenail in that picture. They will often be, obvious or more obvious from preschool sort of years, but may not occur until adolescence or a bit later. And the periungual fibromas are more likely to be in adolescence or adulthood. Then you've got other findings, and they also have different ages of likely onset. So that's the eye findings, like the retinal hamartomas, you can sometimes see from quite a young age and into childhood. The renal changes, the angiomyolipomas, often not until, mid-childhood and then into sort of adult life. And the pulmonary leiomyomatosis is usually not until adult life, and it's more common in females than males, although it can occur in both. That's just a picture to show you the facial angiofibromas, that sort of raised reddish sort of macules there, papules. Okay. All right, so moving on, because I'm sure again that a lot of you know about TSC, so you probably don't need me to go into detail about it. So I thought I'd start with Genetics 101. Who among you has any genetic background, or you've seen a genetic service, or so you've probably had a bit of a chat with someone like myself about what genetics involves. So basically, humans are made of billions, trillions of cells, and this is essentially a cartoon of what a cell looks like. So the center of the cell, or the nucleus, contains these things called chromosomes, and this is just a picture of a chromosome spread up here. Your chromosomes are essentially the packages that contain your genetic information, and that genetic information is your DNA, which is this ladder-like sort of double helical structure that you see here. So if you unravel a chromosome, it's a bit like unraveling a ball of wool. You get this long strand of DNA that goes on forever. And the DNA is composed of these bases, nucleotide bases, and they're essentially 4 letters, which represent the 4 deoxyribonucleic acid bases, T, A, C, and G. And the order of those bases, when the body comes along and reads through the recipe of a gene, will tell it how the recipe needs to be read and used. So if you look at these chromosomes, lined up along all those chromosomes are approximately 20,000 genes. And each gene is like a chemical recipe book that your body has to read through to make or do something to keep your body healthy and developing normally. There you can see that they're all arranged in pairs. So there's 46 chromosomes in every cell, arranged in 23 pairs. They don't look nicely arranged in pairs like that in a cell in the body. They look a bit of a jumble, a bit like this. But when they look at chromosomes in the laboratory, they line them up so they can tell which one's which and, you know, what they're looking at. The reason for the pairs is that we get 1 copy of each pair of chromosomes and therefore 1 copy of each gene from our mother in the egg and 1 copy from our father in the sperm. And then, of course, when the sperm comes along and fertilizes the egg and makes the first cell and a new baby, they've got the usual number of chromosomes and 20,000 pairs of genes. Okay, so as I said before when we started, this is an autosomal dominant genetic condition. So you only need a fault in one of the 2 copies of the gene to have TSC. And this is a condition that's got what we call complete penetrance, meaning that you will see signs of the condition if you've got it. It's not something that that you can have a genetic change for TSC, but have absolutely nothing to suggest that you've got it clinically. But there is variable expressivity, meaning that not everyone will have the same degree of effect from the TSC, that it can be milder in some individuals or more severe in other individuals. And although there are some correlations from a genetic point of view with severity, it's not easy to necessarily predict how severe someone might be from a clinical effect point of view, just based on what you find in a person's genetics. Okay, and that can be the same in the same family, because as you know, obviously there are families where multiple generations of individuals have TSC, and if you look at those families, some of them have more significant issues and some have much milder issues. And a lot of that is probably based on the fact that we're all very unique individuals, and in addition to having a change in one of the TSC genes, that person also has those other 20,000 pairs of genes, and they'll have other genetic factors, I suppose, that could modify the effect of having the TSC gene change. Okay, so dominant inheritance, this is just a representation of the 2 genes, TSC1 on chromosome number 9, and this just illustrates that this chromosome, the TSC1 gene, works fine, and this copy isn't working. And in the TSC2 gene, which is on chromosome 16, this copy works fine, and this copy's got a fault in it that means that gene is not working. And this is an illustration of how that inheritance works. So in this case, if we say that dad's got TSC, the big D represents the faulty copy of the TSC gene, then every time he passes on his genetic information, he can pass on either the faulty copy of that gene or the working copy. And his partner, if we assume she doesn't have TSC, will always pass on a working copy, which means that 50% of the time, Dad might pass on the faulty copy of the gene. So that's where the 50-50 chance comes from if a parent has TSC in terms of passing it on to their children. Now, it looks like that's just a nice 1 in 2 chance. So if you have 2 children, 1 will have it and 1 won't. If you have 4 children, 2 will have it and 2 won't. Of course, nature doesn't work that way, and it depends how you flip those 2 coins. So, someone who has TSC could flip those 2 coins 4 times, and they might come up tails each time and maybe not pass on the TSC gene change, or they might pass on the TSC gene change 100% of the time. And that's because we all have relatively small numbers of children. If all of us had 100 or more children, you'd probably see that the 50% figure would roughly work out. But, if you only have a few children, obviously it depends which coins get flipped. Okay, and again, just to go through autosomal dominant inheritance, 1 copy of a gene not working is sufficient, and it doesn't matter whether you're male or female, doesn't make any difference. So 50-50 chance we've talked about penetrance and expressivity. And of course, it's possible that this could have arisen as a new change in that child in the first instance. So in other words, this has got to start somewhere, and it may not have been present in one or other parent. It may have developed as a new change in that gene recipe in that particular child who's been diagnosed with TSC. So this is just a representation of a family tree, and the black squares or circles represent those individuals with TSC, and you can see that this person has passed on TSC to 2 of his 4 children, and then this person has passed it on to 2 of her 3 children. And of course, if you don't inherit this TSC gene change, then you can't pass it on in turn. So then you don't need to worry about the possibility that your children might have that condition. Okay, so I guess we've sort of addressed this question. Is TSC always inherited from a parent? Often not. Probably in about 2/3 of cases, it does arise as a new or de novo change in that child. But about in 1/3 of cases, it is inherited from a parent. And sometimes that's known. So, a parent might know that they have TSC and, therefore know that they do have a chance of passing it on. But sometimes if they're mildly affected, no one's picked up that they've got, the typical skin lesions, or, they've never had any specific issues with seizures or significant developmental issues or kidney issues, then they may not know until their child's diagnosed with TSC that they also have it. And of course, it can be what we call mosaic in the child, where they've got the change in the TSC1 or 2 gene in some cells of their body, but not all cells. And that can sometimes affect how mild or severe the condition might be. So if you've got, it in some cells, but not every cell, then you might expect that the effect might be milder. But because we can't easily work out which cells, the change is present in that situation, it's still quite hard to know. And that's a reason also that we may not be able to find the causative gene variant when we do routine blood DNA testing. And we'll talk a little bit more about that. So the question then is, well, okay, is it possible to have another child? So if you've had 1 child with TSC, and it doesn't look like you have TSC, either you or your partner, can you have another child with TSC? And the answer to that is that it's possible. There's a very small chance when neither parent obviously has TSC. And that's because, as I said, these gene changes have to start somewhere. So in this situation, it may have started at the time of that child's conception in the egg or sperm that made that child. It might have started a little bit after that child's conception in a cell that then develops that change change in other cells. That's mosaicism. But it's also possible that it could have occurred in mum or dad, but not right from the time of their conception, but down the track. And if that happens to have occurred in the ovary or the testis, so in egg cells or sperm cells, then you might have what we gonadal mosaicism for TSC, which means that, again, that change is present in some cells, including the germline, but not all cells. And that means that there is a theoretical chance, if we can't determine that either parent has TSC, that they might have another child with that condition. But the chance is still low. It's less than 1%. So that's often a bit of a difficult thing to get your head around. But, you know, if we are in the situation where we have seen a child who's got TSC, we've done genetic testing, we've identified the specific change in the gene that's caused it in that child, then we test mum and dad and neither of them obviously has it and they have no other clinical signs of TSC, then we would say that if you're planning more children, the chance is extremely low that you'll have another child with TSC, but it's not zero. It's probably in the region of 1% or less. Okay, and that's that risk of gonadal mosaicism. Okay, so I mentioned before that there are some correlations between specific TSC1 or 2 gene variants and the severity of TSC, but it's not, you know, an absolute thing. Generally speaking, if you've got a change in TSC2, that tends to be associated with a more severe clinical picture than if you've got a variant in TSC1. And in particular, there seems to be a greater chance of renal angiomyolopomas or AMLs and renal cancer. Significant developmental delay by age 2 associated with other things like intellectual disability, autism and infantile spasms. The cardiac rhabdomyomas are more likely if you've got a TSC2 change, and facial angiofibromas seem to be more common. But as I said, it's not a definite correlation because there are certainly individuals who have changes in TSC2 who are much more mildly affected, and there are individuals who have changes in TSC1 who are more severely affected. And there are some specific gene variants, so specific changes in the gene that seem to have been associated with milder clinical features, but again, there can be variability. Very rarely you can get a larger deletion on chromosome 16 that involves the TSC2 gene and the adjacent PKD1 gene, which is associated with autosomal dominant polycystic kidney disease, where you get multiple cysts in the kidneys. And because you can get cystic change in the kidneys in TSC, you know, that can just mean that the kidney issues can be more significant for that individual, and it's associated generally with a more significant clinical picture overall. We wouldn't routinely do chromosome testing, which is what you'd need to do usually to identify something like that, unless you actually thought that there was something more going on than just isolated TSC. So it's not the sort of baseline or initial line of investigation. Okay, so what does diagnostic genetic testing involve? Okay, so if we suspect that a child, or an adult for that matter, has TSC, then we'd aim to get initially a blood sample from them, and we'd ask the laboratory to extract the DNA from that sample and then analyse it for changes within those genes. So the approach to that sounds very straightforward, but the approach to the testing can depend a bit on the clinical picture. So if you're really sure that this person's got TSC, so they meet all the clinical diagnostic criteria that we talked about before, then we would take a targeted approach. So we'd ask the laboratory to specifically look at those 2 genes. If it's suspected TSC, we may still target those 2 genes, but if it's less clear that this is TSC, we might take a broader approach. So an example of that is that, you know, you might have a child presenting with epilepsy, for example, infantile spasms, and, you know, maybe they don't have other features that clearly suggest TSC. So instead of targeting very specifically the TSC1 and 2 genes, the treating doctor might request a broader panel of genes, for example, a panel of epilepsy genes. Genes are known to be associated with various types of epilepsy. And the TSC genes are on those panels. And so you sometimes make that diagnosis because you've done a broader panel and you found that a child has a change in TSC1 or 2. Not everyone with TSC will have the same gene variant, so there can be many different variants within the genes that can cause TSC. So unfortunately, it's not as straightforward as just saying we want to look at those 2 genes and we're looking for the specific spelling mistake in chapter 2, line 3, that changes a G to a T or something like that. Unfortunately, they're sort of spread throughout the gene, and sometimes it's not actually possible to find the underlying causative genetic fault. And that's just because of the limitations of genetic testing technology, and because genes are a tricky thing sometimes to look at. Okay, so why would we bother with genetic testing when initially I talked about the fact that, often we can make the diagnosis clinically and you don't need the genetic test to confirm it? Okay, well, if we do identify a pathogenic or causative variant in one of these genes, it confirms the diagnosis. So it does give some certainty when that is a bit unclear. It also often will reduce the need for unnecessary additional investigations. It's sometimes useful if people are thinking about having further children to give them information about how likely it is that they could pass something on, or what the chance is that another child could have the condition. And it provides information also to the broader family. So, for example, if you know that a child has TSC, you've identified the genetic change in that child, you've tested mum and dad, they don't have TSC, they don't have that genetic change, then not only does it mean that their chance of having another child with TSC is very low, but it also means that other family members don't need to be concerned about the possibility that they might have TSC. If, of course, one parent then is found to have that same genetic change, then the question is, well, where did they get that from? Could they have inherited that from their mum or dad? And therefore, could their siblings also potentially have inherited it? Or was it a new change in them, as it can be sometimes in children when we diagnose TSC? Of course, the other reason now for genetic testing is for management purposes. So there's been a lot of recent work done and a number of clinical trials looking at early surveillance and early treatment to see if that makes a difference to outcomes. So, for example, there's good evidence from some of these clinical trials that starting a medication called vigabatrin, which is an anti-seizure medication that does actually act on that mTORC1 pathway involved in TSC. As soon as you actually detect any EEG abnormalities, even before you've had any clinical seizures, actually can reduce the severity and delay the onset of seizures, and that potentially might reduce the chance of intellectual disability, although there's still ongoing work in relation to that. So, in other words, rather than waiting until you've got all the clinical features, if you suspect that someone has TSC and you can do genetic testing that can confirm that, then you would actually put in place a surveillance program where you would actually want to do EEGs on a very regular basis in a young baby, monitoring for any evidence of seizure activity. And if there was any evidence, even in the absence of any seizures, then you would want to probably start medication. So that's a reason for thinking about genetic testing early rather than delaying it. Okay, now this is a bit of a busy slide. I took it from a recent publication from the Journal of Pediatrics and Child Health, just to give you a bit of an overview of some of the trials and so on that have been done in this area. So it's not something I expect that you will memorise or want to, take away with you necessarily, but this is the TSC1 and 2 genes that interact together with those 2 proteins. And basically, when they're not working, you get an overactive mTOR pathway, and that can lead to abnormal cell growth and uncontrolled growth, which is why you get all those growths like the tubers and the SIGAs and the renal AMLs and potentially the lung changes. And you can also get atypical connectivity in brain cells and so on, which, affects things like EEG discharges and seizure activity and intellectual activity. And so that just lists some of the trials that they've looked at in relation to using those medications early. So there's trials called EpiStop and Prevent that looked at early vigabatrin. And either from the time when a child started to have clinical seizures or before that when they had EEG changes only. And these are the trials that have shown, led to some of these changes and how management is done now. So I won't sort of dwell on that because that's not potentially what we're here for. Okay. So that was genetic testing in terms of, yes, we found the cause for the TSC in your child or your family. We can test other individuals. There's reproductive options, which I'll talk about. But of course, we don't always find the underlying cause. So what are the other possible outcomes of genetic testing? One that's not an uncommon finding for any genetic condition is that we find what's called a variant of uncertain significance, or VUS, in one of these genes, which is essentially a variation in the recipe of the gene, but there's not enough information in the medical literature or databases that we have access to know for sure that it causes a problem with the way that the gene works. And then it becomes really tricky because while it might be the cause, it's in the right gene, we think this child has TSC, it's always hard to know for sure, and you don't necessarily want to be making important decisions based on information that's unclear. So a variant of uncertain significance is not something that I would normally recommend is used for family testing to know whether or not someone's got TSC, or for decision making when you're thinking about testing in a pregnancy or in a reproductive setting. Because you might be, if it turns out not to be the cause, then you might be making decisions thinking that a child does have TSC when they don't, or vice versa. Okay, the other possibility, of course, is that we don't find anything. So we've looked in TSC 1 and 2, didn't find any abnormalities at all. So then the question is, well, does that mean it's not TSC? Clinically, if a person has all of the relevant features and meets the diagnostic criteria, then they still have TSC. It's just that we've not found the underlying cause. Could it be, that there's some other gene that causes TSC that we don't yet know about? It's always theoretically possible because there's many thousands of genes we still don't understand the function of. But to date, we've known about TSC 1 and 2 for many, many years now, even since I was a young geneticist many years ago. And, we still haven't found a third or more gene that causes TSC. So who knows? And of course, the other reason we may not find something is because that person is mosaic for that gene change. And because it's present in some but not all cells, it depends what tissue you're looking at as to whether or not you might find something. So, for example, if you have a change in the TSC1 or 2 gene in, say, kidney cells, but it's not in blood, then you may not find it when you go looking in DNA extracted from blood. We're not necessarily going to go and biopsy a kidney to actually do genetic testing, but sometimes we will, look at other tissues that appear to be affected with TSC. So, for example, if you've got something like a shagreen patch on the skin or a hypomelanotic macule, or an angiofibroma, then you might be able to do a biopsy of a skin lesion and ask the laboratory to go looking in those genes again. Of course, that's not always easily available, and even if you're looking at a tissue that you think, well, there should be something here because this tissue is obviously affected with TSC. You know, it's got the changes associated with TSC. You still may not find something, and that can be also depend on the sampling. It can also depend on the level of mosaicism. So we can be talking quite low levels of that TSC1 or 2 gene change in some of these cells. And routine genetic testing, which is what's available in most laboratories, will generally get down to maybe a sort of a 10 to 20% chance of finding something at a mosaic level, but anything much below 10%, and they may not find it even if it's there. And there are in some places options to do what's called deep sequencing, to really look very hard at tissues for a change in those genes, but although that's getting easier to access, it's still not easily accessible, you know, from a diagnostic point of view everywhere. So it is hard to do. I mean, I have in one situation managed to find it in sperm. Well, I haven't found it in sperm. I'm not a laboratory person, but I did arrange to send it off somewhere, to send a sperm sample off somewhere and actually identified the TSC change in sperm. Our laboratory were quite interested in that. They hadn't dealt with sperm before and packaging that off and sending it off to someone else. So, that was an interesting situation. Okay, all right. This has got nothing to do with TSC, but this is, I guess, a picture of mosaicism. So this is a cat, a tortoiseshell cat, that actually has different coloured eyes and different coloured fur, and that's because tortoiseshell cats are mosaic. They've got different changes in different cells. So that just gives you an example of mosaicism in action, not because it's specifically related to TSC. Reproductive decision making, I guess that's one of the areas. I mean, apart from management and early intervention and, you know, trying to prevent adverse outcomes from TSC, the other area that's really important for families sometimes is reproductive decision making and having options from that point of view. So if you know what the underlying genetic cause for the TSC in the family is, then your options for reproduction do expand. But any decisions around reproduction are very personal decisions, and they very much depend on the individual parent, the individual couple, how they feel about TSC, how they feel about the possibility of having another child with TSC, or if they know that they might, you know, they haven't yet had children, but they have TSC, how they feel about that. And not everyone will make the same sorts of decisions when they're thinking about this. So that's really important to know. And that's something that from a genetic perspective, we're always very clear about, that we don't tell people what they should or shouldn't do in this setting. This is very much a decision that is made based on the information that we can provide to a family to help them know what the options are. Okay. The options, of course, you know, if you know what the underlying cause is, include doing nothing. So you might say, I don't mind if I have another child with TSC, this would not be an issue for me, and I would not do anything different. I wouldn't test in a pregnancy. I could still test my baby after delivery to know if they, you know, have TSC, so that we could do something about management if need be, but I wouldn't do anything different in a pregnancy. Sometimes, of course, people might still want to test in a pregnancy just to know, so that they can prepare for baby's delivery and potential monitoring after delivery. But of course, if you didn't want to pass on TSC to a child, then you can have prenatal diagnosis from around 11 to 13 weeks of a pregnancy, and I'll show you some diagrams of that. But of course, the only way not to pass it on in that situation is to say, well, look, if I know baby has it, I would choose to end the pregnancy, which is obviously not an easy decision to make. The other option, if you didn't want to pass it on, would be to go through IVF and what's called pre-implantation genetic testing of early stage embryos, where basically a few cells from an early embryo from about a day 5 stage are collected and sent for testing. It's a more complicated testing process, so it has to be sort of worked up in advance because you're working with very limited amounts of DNA. But, it is also possible. And then you would choose not to return or not to start a pregnancy with an embryo that's been shown to have TSC. Other options, of course, and we talk about these with families, but many people would choose not to go down these routes, but you can choose donor egg, donor sperm, donor embryo. So if mum's got TSC, she might choose to use donor egg. If dad's got TSC, they might choose to use donor sperm, and they might choose donor embryo. And of course, adoption, is also a possibility, although all of those have their own pros and cons. Okay, so prenatal diagnosis, chorionic villus sampling is where an obstetric specialist who does this all the time under ultrasound guidance will then pop a needle into mum's uterus and collect a little bit of the placenta, and then that is sent off for genetic testing. There is a small chance of contamination from mum cells, although the laboratory usually looks for that, and they can let you know if it's occurred, and you can either repeat the procedure or you can go on to amniocentesis. The chance of miscarriage in this setting in experienced hands is about 1 in 500, because obviously you're popping a foreign body into the uterus, so sometimes that can precipitate labour, but it's pretty low chance. Amniocentesis is very similar, except instead of taking placenta, you take a little bit of the amniotic fluid, and that's probably more representative of baby cells. It's less likely to run, you're not likely to run into trouble with contamination from mum cells, and the chance of miscarriage from the procedure itself is around 1 in 1,000. So it's a pretty low chance of any complications, but of course it does mean that you might need to make a decision about whether you continue a pregnancy. IVF and PGT, in this case PGT-M, when there's a known genetic condition, is done through a fertility service. We talked about an initial workup that's required for family-specific testing, and as part of that testing you can also ask them to analyse for large chromosome differences in an embryo that might also impact whether you would use an embryo. Okay, so pros and cons of prenatal versus IVF and pre-implantation testing. Prenatal testing, it's a natural conception, so it's the usual fun way of getting pregnant, but there's obviously reduced cost associated with that, but there is a small risk of miscarriage, and there's a need to consider whether or not you would end a pregnancy. IVF and PGT, you will potentially rule out affected embryos prior to starting a pregnancy, which means you don't have to worry so much about the pregnancy itself. Although there is still, an out-of-pocket cost associated with this, despite the fact that there are now Medicare rebates for the testing process itself, which there never used to be. The other thing, of course, is, the success of IVF will depend on, because it relies on giving a prospective mother medication to stimulate the ovaries to produce multiple eggs to maturity at once, collect those eggs, fertilise them outside the uterus with dad's sperm, and then grow them up and test them. And so obviously there can be attrition at every stage of that. It will depend how many eggs are produced, how many then make it to fertilisation, how many embryos then get to the stage of testing, and of course then you test them, and if there's a 50% chance of them having TSC, then you potentially rule out 50% or more. So it sometimes requires multiple IVF cycles to actually get enough embryos to start the whole process. And of course, the other thing that no one knows necessarily is that finding the genetic variant in baby during prenatal testing or IVF doesn't predict how severe they may or may not be affected. I thought I'd talk briefly about other available pre-pregnancy screening tests, which may be relevant for some people who are listening. which is not necessarily associated with TSC itself. But we now have available reproductive carrier screening, which will screen for a variable number of autosomal recessive, where both parents need to be carriers, meaning they've got one faulty copy and one working copy of the gene. But a recessive condition, if you're a carrier, you're healthy, you don't have the condition. But if both parents are carriers and they both pass it on to a child, there's a 1 in 4 chance that that child could have that condition. And the other thing that can be screened for are some X-linked recessive conditions where mum can be a carrier of a change on the X chromosome, and if they pass that to a son who only has one X chromosome and no backup copy of that gene, then that could cause problems. So there's currently a Medicare-funded 3-gene screen that screens for 2 recessive conditions called spinal muscular atrophy, cystic fibrosis, and 1 X-linked intellectual disability condition called Fragile X syndrome. And there are other commercial options at cost that will screen a variable number of genes, so you can look for several hundred conditions potentially. But it will not detect TSC because that's an autosomal dominant genetic condition, and that's not what the aim of this screening is for. So really this slide is really to say, yes, this is available, and it could be an add-on, if you want to make sure as far as possible that you might not have a chance of having a child with some other condition, but it's not something you could use to reliably detect TSC. Oh, hello, and yes, we have got to the end.